In this video, I will be talking about first-line therapy for stage 4 metastatic or locally advanced unresectable gastroesophageal adenocarcinoma that is HER2 negative, PDL1 negative low, and Claudin negative, or triple negative. In the recent series of videos, we've been talking about the stage of advanced disease, stage 4 metastatic, already spread outside of the original site, or locally advanced but unresectable for whatever reason. And in general, we've talked about how this therapy is considered palliative for the most part. In the most recent series of videos, we looked at biomarker profiling specifically for HER2, PDL1, and Claudin expression, or gene amplification in the setting of HER2, and their matched targeted therapies. And so now we're going to be talking about a relatively large subgroup of patients that happen to be negative for these three biomarkers. I've been talking about Claudin as if it is a routine thing to do because I think it's just a matter of time. But as of June of 2023, when this video is being made, it's currently not yet FDA approved. And so in the meantime, historically, it has been HER2 positive or HER2 negative. And then over the last years, PDL1 inhibitors, PD1 inhibitors, with specifically nivolumab and pembrolizumab, have been approved. And now we expect zolbetuximab for Claudin positive. So what do we do, though, if all of those biomarkers are negative? That is the focus of this discussion here. So remember the TCGA, the Cancer Genome Atlas, which was a profiling effort of hundreds of samples from the locally advanced and localized setting, stage 1 to 3. And from that effort of gene sequencing and protein expression, a clustering of tumor types that were similar to each other was done. And for adenocarcinomas, the four main subgroups derived were chromosomal unstable, Epstein-Barr virus positive, MSI-H tumors, and genomically stable tumor, as opposed to esophageal squamous cell cancers, which were considered a different entity, not adenocarcinomas. And remember, now with the three biomarkers that are or will be standard at the newly diagnosed setting to test for, the incidences of HER2 positivity range from 10 to 15%, depending on which study or what cohort we're looking at. I also mentioned in that talk that gastric cancer is about 10%, and G-junction esophageal adenocarcinoma is a little bit higher. And for PDL1 expression by combined positivity score, depending on what cutoff you use, if you use 10, which is my preference, versus 5, I think is the minimum you should go. The incidence also ranges, and my estimates here are 15 to 30% incidence that will have a 10 score or higher, and 30 to 45% that will have a 5 score or higher. Now, some of the clinical trials, the phase 3 studies, have shown the incidences of 10 or higher to be up to even 50% of the cases, and for the CPS5 to be 60, 65% of the cases. But I think those are overestimates. I mentioned that in previous talks. I for whatever reason, it's unclear, but I propose a few possibilities. But regardless, I think in the real world, this is more in tune with what the actual incidences of these two cutoffs would be. And then in the most recent video about zolbetuximab and Claudin 18.2, we saw that the incidence is around 25 to 35%. And we also know that there's some co-incidence of these where they may both be positive. And so you can't just add these percentages up, and because some of them will be double positive or some will be double negative. So what about the HER2 negative, PDL1 negative, and Claudin 18.2 negative tumors? What's the incidence of this? And do they have a higher incidence in one of these subgroups? Well, some of this is not well established yet because this is all relatively new, especially when you superimpose Claudin, the newest biomarker. But in general, my sense will be that the incidence is going to be, on a conservative estimate, around 40 to 50% of the patients will still be negative for all of these biomarkers. And it may even be higher than that, in the real world. Certainly, the diffuse type gastric cancers, signet ring tumors, genomically stables are generally negative for each of these biomarkers, except for CLDN18.2. That one is actually thought to be maybe even a little bit higher than 25 to 35, maybe even up to 40%. And so maybe genomically stable tumors, though, will have a higher percentage that are all negative, as opposed to MSI-high tumors and EBV positive tumors I mentioned in those talks, that they tend to be high in PDL1 and they should be getting immunotherapies. And then finally, the chromosomal unstable group, which is, as you can see, the majority of patients, certainly in the GE junction and esophagus, but even in the gastric cancers, where it's more than half. These patients can be HER2 positive, can have high PDL1 scores, can have claudin positivity, but I still think a large component of these tumors will still be at around half of the patients will be negative for all of them. So it's a pertinent discussion here because I think it encompasses a lot of patients. So we've shown here this figure where we are plotting the median overall survivals. And again, this is the median, meaning half of patients are alive, half of patients are not alive from the time of diagnosis. And today, the median survival with chemotherapy alone in most phase 3 studies in the last 5-10 years is around 12 months. And we plotted here in green 2-drug regimens and in orange 3-drug regimens. So I also mentioned that FOLFOX chemotherapy is a preferred first-line chemotherapy backbone, doublet chemotherapy. And so the general outcomes that one might expect with chemotherapy alone are on this slide. And you can see here with FOLFOX, expected response rates, disease control rate, progression-free survival median, and overall survival median. And the medians I have always mentioned that are creeping up over the years, not only because of improved first-line therapy, but also because we've had better therapies in next line, second line, third line, even higher, that helps to improve overall survival. But what about for triple negatives, HER2 negative, PDL1 negative, and claudin negative? Because we don't have any targeted options, is this what we have is doublet chemotherapy? Essentially, that is it. However, we also had a specific presentation on triplet chemotherapy in the first line setting of stage 4 or advanced disease. This may be useful here in triple negatives because there's not a third agent, a targeted therapy to go with as there would be in each of these positive groups. So what was the evidence? We showed that in that previous presentation, but briefly it's summarized here on the slide where different regimens that are 3 drugs adding to platinum and 5-FU. So this is DCF, which is docetaxel, cisplatin, and 5-FU. And this study was actually randomized to a standard dosing, which was considered standard dosing of DCF, or a modified version with slightly lower dosing to try and make it more tolerable. And then we have the FLOT regimen, which we are familiar with from the perioperative setting, but also could be used in the first line setting. And there are some studies that support that. And you can see the outcomes here. And then finally, there's FOLFIRINOX, which is oxaliplatin, 5-FU, and irinotecan, as opposed to 5-FU, oxaliplatin, docetaxel, or taxotere, and FLOT. And so with these 3 different 3-drug regimens, you can see that overall response rates are probably slightly higher compared to doublet regimens, although these are not being compared to a doublet chemotherapy. These are all single-arm studies or randomizing to do different triplet regimens. And so overall, the sense was that, this may have slightly better outcomes compared to doublet with a little bit higher response rate, a little bit higher progression-free survival, a little bit better median overall survival. But overall, those marginal improvements in each of those are compensated or traded off with higher toxicity rates of these 3-drug chemo regimens. And so it's not a routine thing to recommend for most patients. That said, even though it's generally preferred to do doublet regimens, there may be instances to use 3-drug regimens. And my opinion, of course, I mentioned is I prefer FOLFIRINOX modified without a 5-FU bolus to make them more tolerable. and because it doesn't have both oxaliplatin and docetaxel, which are both neurotoxic. Here, only oxaliplatin is the neurotoxic agent in FOLFIRINOX. So when would we use a 3-drug regimen? In the previous presentation, we noted a number of different reasons why one would consider using it. Of course, outside of the standard, using it in the curative setting, in the perioperative setting, in early stage disease, stage 2 and 3, there were other instances, like in the stage 4 setting, if you have high disease burden, lots of symptoms. We're going to be talking about a scenario where you have stage 4 disease, but very minimal sites of spread. But of course, now we can add here a triple negative group, which doesn't have a targeted therapy option to go after. And so, especially if you have some of these other things going on. And I mentioned that triple negative tumors are a little bit higher in the genomically stable, the signet ring, and diffuse type. And so fusions, ascites, and things like that, where responses are really desirable, you might start with a triple regimen to go after it and then tailor off the drugs as you can. So remember, we always have to balance this with this trade-off, and those trade-offs, when you add the third chemo drug, you have higher side effect profile, neuropathies, cytopenias, low blood counts, where you need a growth factor shot to help boost up your white blood cells, specifically your neutrophils, to prevent infection, diarrhea, and etc., fatigue, that are all higher with triplet regimens. And so, again, I'll just point out, I'm bringing it up here in this presentation because we're talking about triple negative tumors. And if we don't have a better targeted therapy option, one could consider a triplet regimen here, and especially if there's other things going on with symptoms and disease burden. So this is summarized in the NCCN guidelines, which we've been showing, where we've highlighted here for HER2 negative tumors, because of course HER2 positive tumors are going to be getting targeted therapy with trastuzumab. And we also mentioned that the Claudin story isn't in this set of guidelines yet, because we're awaiting FDA approval. But at the moment, what we do see here is that checkpoint inhibitors, anti-PD-1 therapies, are listed here. And for PDL1 scores, specifically for higher cutoff scores, 5 and 10 for nivolumab and pembrolizumab, respectively, both for esophagus and G junction, as well as for stomach. And so we also see here for gastric and for esophagus and G junction, just chemotherapy without targeted agents. And of course, those would be for patients that don't have a better target to go after, is to use doublet chemotherapy. And of course, oxaliplatin is preferred over cisplatin in both situations. So I will also point out here that you do have other recommended regimens, could be triplet regimens like DCF or DOF. FOLFIRINOX is not listed here, but of course that isn't. So this summary down here, where we were talking about looking at the biomarker profiles and then, logically assigning therapy with or without a targeted therapy. And so what we're talking about here today is if you're negative for PDL1 and Claudin, where here you're talking about chemotherapy alone, doublet, or maybe triplet in certain cases. And in the setting where your Claudin is negative and you have an equivocal level of PDL1, of course, you could use just chemotherapy doublet. You could use a triplet, or here you might consider using the anti-PD-1 checkpoint inhibitor, even though it's equivocal, because there's not much else to go for. So that's also summarized here in the rationale of how I come to those decisions in looking at immunotherapy studies, the key ones for gastric and G junction cancers here, with Checkmate 649 looking at nivolumab, and Keynote 859, a recent study looking at pembrolizumab. And you can see that although in all comers there seemed to be a benefit, it's really isolated to the higher levels of PDL1, where the benefits above 10 are really is where it's at, and those less than 10, there's really no benefit. Similarly, for the Claudin story, that study, the Spotlight study, and also the GLOW study, only allowed patients that had positive expression of Claudin into the study. So it will only be available for these patients. And so looking at all the different possibilities in the tumor, you can see that what we're talking about here today is those that are low for PDL1 and negative for Claudin, and of course, amongst HER2 negative tumors. And that's still going to be a large proportion of patients. And so this is getting complicated where we're having to get biomarker profiles at the time of diagnosis and then stratify patients into different groups to determine what their best therapies are. And it will get even more complicated if we start to include other biomarkers that are already established or emerging. And so we're going to be talking about in the rest of this talk other potential biomarkers for this triple negative group. Triple negative meaning HER2 negative, PDL1 negative, and Claudin negative. And we're other potential targets that one would consider, EGFR, MET, and FGFR2. So remember, in the principles of molecular profiling and biomarker testing in the tissue, we talked about how there are a number of different sources of getting the sample, how it's processed, and how the pathologist determines if there's cancer there. And then also specifically looking at routine biomarkers. And now we're talking about in the setting of where you have a negative HER2 test, negative PDL1 test, not MSI-H, and not Claudin when that becomes routinely tested. But we do have, in addition to that, routine testing with next generation sequencing of DNA. And we talked about why that's useful is because we get all the different types of genetic events, the four main classes, across hundreds of genes simultaneously. So you don't have to pick each one individually. And there are a number of commercial assays available, as well as most academic centers have some internal panels. And so what we're talking about here now in the setting of gastroesophageal adenocarcinoma that are triple negative for the routine biomarkers, HER2, PDL1 with MSI-H in brackets, and Claudin, is those that have copy number alterations. And so when we look at an example of a list of genes that are included in the routine next generation sequencing panel, this is an example of Foundation 1, that we are really talking about these three high yield biomarkers, EGFR, FGFR2, and MET. So remember, the chromosomal instability group, which again is the majority of patients. And remember, I also mentioned that the incidences that are shown here in this figure represent earlier stage disease, stage 1, 2, and 3. And actually, the incidences in the stage 4 setting of each of these four main categories are slightly different. MSI-H group is less than this. EBV positive is less than this. And so the CIN group becomes even more common, and the genomically stable a little bit more common than in what is represented from this particular figure. And so chromosomal instability, though, has a hallmark of gene copy number increase, amplifying tumors. And so the ones that are key ones that we have actual targeted therapies available for are listed here. So one of those, HER2, we've spent a lot of time, and that's a standard thing to test for and has been shown to be beneficial. What I'm going to show you now are some evidence of studies and reports that suggest that the same is true for each of these three genes. So remember, in the principles of targeted therapy, we went through receptor tyrosine kinases and how these are often genetically abnormal in cancer because they are the node that tells the cancer to grow. And so when it becomes genetically abnormal, whereas compared to the normal cell, if you have normal gene copy, you have normal expression of the receptor at the cell surface. But in the setting of HER2 amplification in this figure, you see a ton of HER2 protein at the receptor, and so it's signaling inappropriately all the time and telling the cells to grow. And so this is not unique to HER2. Now we're going to talk about MET amplification, EGFR amplification, and FGFR2. So again, in that talk on targeted therapies, we talked about antibodies versus small molecules. And yes, we talked about trastuzumab and zolbetuximab so far, as well as not listed here, the immunotherapy drugs like PD-1 inhibitors. But now we're going to talk about other antibodies to other proteins, namely EGFR, FGFR2. There are newer drugs that are coming out that are bispecific for more than one receptor, like this drug, which is recently approved in lung cancer for both MET and EGFR. And then we'll also look at tyrosine kinase inhibitors, oral drugs of which there are a number of examples that inhibit the various receptors of interest. And I'll show you some data specifically for MET tyrosine kinase inhibitor. So we looked at this figure when we were talking about HER2, just to show again that the receptor at the surface of the cell dimerizes with other receptors at the cell and leads to signaling to the nucleus of the cell that then changes the transcription, the expression of different proteins in a pro-growth phase. And so what else is shown here is how different drugs have been designed to inhibit that signal, from antibodies, which bind to the outside of the receptor, to small molecule inhibitors that come in through the cell, get into the cell, and bind on the inside of the receptor. Both are designed to inhibit or shut down the signaling from this receptor. And so, similar to all the drugs we talked about for HER2, there are drugs that do the same thing for EGFR, for MET, and for FGFR2. So you would replace, the label of HER2 with each of these, and you have a receptor that's a MET receptor. And so there are antibodies commercially available on the first line of each of these as examples, and there are oral small molecule inhibitors available on the second line. Remember, my preference to inhibit a target, a receptor tyrosine kinase specifically, is an antibody because it's more specific, it tends to be less side effects, and it's more easily combined with, say, chemotherapy or other drugs. And we've also talked about how combining therapies is often the best way to attack the cancer. And so monoclonal antibodies, remember, they work by inhibiting the receptor through a number of different ways. One is that they can block it from dimerizing, from binding to other receptors, and therefore block it from being activated. They can cause it to become internalized into the cell and degraded, so there's no more receptor on the surface. And a specifically important one is that it can elicit an immune response by dragging in natural killer cells into the area so that the immune system cells can kill the cancer too. So monoclonal antibodies have a number of different ways that they work to control the cancer. And so now, with that brief background, what is the evidence for other first-line therapies, specific targeted therapies, in the setting of where we have triple negativity of HER2, PDL1, and FLOT? So the first gene I'm going to talk about is EGFR. EGFR is amplified, gene amplified in about 5 to 7% of gastroesophageal adenocarcinoma, a little bit higher in the G-junction esophagus compared to the stomach, again, because there's more chromosomal instability tumors in the G-junction esophagus. And that's true for HER2, for EGFR, for MET, and FGFR2. And that said, though, EGFR is expressed to some level in lots of tumors, even in the absence of gene amplification. And so EGFR is a signaling pathway that's common in the cells that line the GI tract, including the stomach and esophagus. And so these agents came around some years ago and showed benefit in colon cancer and started to be studied in gastric and esophageal cancers as well. And so in that era, you can see this was 10 plus years ago, that targeted therapies were sort of given to all patients. And in these two first-line studies looking at two different EGFR therapies, cetuximab and panitumumab, combined with standard chemotherapies at the time, platinum 5-FU, epirubicin platinum 5-FU, and with a placebo control, you can see here that these studies were all negative in all comers, not selecting for any biomarker. And so that was discouraged and essentially led to the abandonment of investigation of EGFR therapies in the disease. There was also studies with oral TKI therapy, EGFR inhibitors with gefitinib, and this was in the second line and higher. And again, this was also new. So again, this was discouraging. However, when we looked at subgroup analysis, we can see here, remember, a forest plot. And so this is overall survival versus and progression-free survival on the right. And you can see that looking at different subgroups by biomarker status. So those that were FISH positive, meaning they had gene amplification versus FISH negative, or if they had true amplification, which is most important. And so as opposed to polysomy, which means you had an increased number of chromosomes that the gene resides on, but not necessarily more genes. And so the ratio of the copy number of the gene to the number of chromosomes that it resides on is really important. So if it's high, a ratio of 2 or higher, that's amplified. And so what you see here is when you have an amplified tumor is that the benefit really favors the targeted therapy, in this case, gefitinib for EGFR amplification. And so what you see here is that although the overall study was negative, there was suggestion that if you used an EGFR targeted therapy in a targeted population of patients driven by EGFR with gene abnormalities, amplification of the gene, then it was effective. That was the second line study that I showed you. In one of the first line studies, the study was called EXPAND with cetuximab. We see another forest plot. This is a forest plot again. On the left here is PFS, this time on the right is overall survival. And what we're showing here is cutoffs of expression by a score called an H score. And so this is a little bit different than the intensity score of 0 to 3 plus, and also the extensity, like what percent of cells are staining. This H score sort of incorporates both components, intensity and amount of cell staining. And so you can see that the maximum score is 300. And so at different cutoffs, as you increase the cutoff to what you call positive, the higher the cutoff, you start to look and see that the patients at the highest cutoffs are starting to derive more benefit. And so this intuitively is telling us that around 5% of the patients are at the highest level. And as you go up in expression by H score, that's where the benefit is really lying, as opposed to the whole where there's no benefit. And in fact, it was leaning towards being better in the chemotherapy alone arm compared to those that were adding cetuximab. It was only those few patients that had a lot of expression. And what we also know is that those tumors that are having such high expression are the ones that are gene amplified. And the incidence is not surprisingly, it's not an accident that the incidence here of the highest expressors is the same incidence of gene amplified tumors. And so we don't have that directly because there wasn't enough sample in all of the tissues remaining after all these tests were done to do gene testing to check for, with FISH, for example, whether or not EGFR was amplified or not to really confirm that. But I mean, it is exactly what one would expect. The high expression level incidence is the same as the high gene cover. And so we see from two of the studies that were large phase 3 studies that the same phenomenon was happening, that it was overall negative, but it worked in a small subset, around 5% of the patients that were either really, really high expressing or those that were having gene amplification. And again, that's the same thing. And so at our center, we did a prospective look at treating patients that we came across with EGFR amplification with targeted therapies. And so of the 150 patients that we saw over those few years, which was around 6% incidence, we treated with EGFR therapies. And if it was first line, we gave them chemotherapy plus an EGFR antibody. If it was second line, we gave them chemotherapy plus an anti-EGFR therapy. If it was third line or higher, we'd give just the EGFR therapy. And you can see our response rates were pretty outstanding. And the disease control rates and progression-free survival were very outstanding. You can see, as an example, in this case, a patient had cancer in the lung and had remarkable shrinkage to not detectable for a long time until it started to regrow. And so this was further evidence, somewhat prospective, but not randomized, certainly, supporting the utility of EGFR therapies in EGFR-driven gene-amplified gastric and esophageal adenocarcinomas. And then we did another study in collaboration with a number of centers across the world. And of the 60 patients accrued, you can see sort of their breakdown and by various factors. Most, again, are GE junction and esophagus, a reflection of that's the majority of patients we see in North America, which was the majority of patients that were enrolled in this global effort, but also because chromosome unstable is more common here compared to stomach. And so you also note that some patients had co-occurrence of HER2 positivity in addition to EGFR amplification. And so that's something to note, is that you could have both of these going on at the same time. And then on the right table, you see here what treatment line they were treated in. And so, like I mentioned, patients were treated with any line that they happened to come into our system, and as soon as we learn that they're EGFR amplified. And you can see the incidence of first line up to fourth line or higher. And then you can see the different types of therapies that were used, and also the actual names of the drugs that were used. And so there's a lot of heterogeneity here. Granted, in this cohort, it's not a homogeneous prospective study, but it's more of a retrospective look, an experience of a lot of different centers trying different agents and strategies when coming across EGFR amplified tumors. And so what's really important, I think, and why I bring this up, is that looking at the response rates of these therapies, whether it's overall the whole cohort, or it's in the patients who got chemo plus an EGFR therapy, or just EGFR therapy alone, the response rates in first line are pretty remarkable compared to what we'd expect with just chemotherapy. It was around 40 to up to 50%. And the same is true for later lines. The response rates are better line for line compared to what one would expect with standard therapies in each of those lines. And then in terms of overall survival for patients, similarly, in first line, color-coded down to fourth line or higher, each of the median overall survivals are higher line for line than what would be expected with just chemotherapy or standard therapies alone in each of those lines. And so, granted, and certainly have to point out that these are small numbers, it's retrospective, it's not homogeneously treated, it's not randomized. And so there's a lot of biases that could be introduced there based on that. Said, this is something to consider for therapy, I would say, in my opinion, based on these data and my own personal experiences. I'll point out, though, for EGFR as well as for MET and FGFR, to date, these are not listed in the NCCN guidance. I'm just pointing out other important evidence that one should be aware of, especially amongst the triple negative tumors, as we've been talking. So the next story is MET amplification, and it's almost the same story as EGFR, and that is that the incidence is very similar, 5 to 7%. There have been a number of studies that were looked at in all comers or in selected patients by just expression, but not gene amplification. So actually, both of these studies, RALO-MET1 and MET gastric, were looking at patients that had overexpression by immunohistochemistry of MET, which amounted to, say, for example, in the RALO-MET study, about 80% of patients screened were eligible and had some expression of MET. Whereas, remember, gene amplification occurs in 5 to 7% of patients. So this was a different patient population. And in addition to that, these drugs, rilotumumab and onartuzumab, two different antibodies from two different companies compared to placebo, were ligand blocking antibodies, not receptor binding. So remember, when we look at a cell, cancer cell, and we see that, in this case, MET receptor in green spanning through the cell membrane is activated by ligands, these red things, hepatocyte growth factor for MET. And so when the ligand binds to one receptor, it brings another receptor in close contact. This is called dimerization, homodimerization, because they're both MET receptors. And that leads to activation of the tyrosine kinase domain internally, and then increased cell signaling and an oncogenic phenotype, proliferation, invasions, cell spreading, etc. And so ligand blocking antibodies, like in these two studies, bind to the ligand and neutralize it. In the setting of MET amplification, these receptors are abundant on the cell membrane, as we've been talking about. And they don't even need the ligand around. There's so much receptor that they just bump into each other randomly, much more than they otherwise would, because there's so much of it. And so they activate themselves automatically, constitutively, even when ligand's not around. So it was anticipated that rituximab and inotuzumab wouldn't work very well in MET amplified tumors, which was only 5 to 7% of all patients. And so the question remained, what if we just gave MET inhibitors to those driven by gene amplification with an actual drug that inhibits the receptor? And so remember, there are two ways to inhibit the receptors. One is with antibodies on the outside, and one is with tyrosine kinase inhibitors, small molecules that are usually oral, that come and diffuse through the membrane into the cell and bind to and inhibit inside the receptor. And so there haven't been any large-scale studies of receptor binding antibodies to date for MET, but there has been a number of tyrosine kinase inhibitor studies. And so probably the best one to show you as an example is this study looking at a drug called AMG 337. AMG is standing for Amgen, and all molecules, when they're being developed, are given a name that's sort of a number. And if it becomes promising, it then gets named. And so this was a drug called AMG 337, and it was a study looking at gastroesophageal adenocarcinomas in this cohort. And so you can see here, though, this difficulty in doing studies when the incidence of the biomarker is so low. Is only 5% of the patients. And so they had to screen more than 2,000 people to identify patients that were MET amplified with any solid tumor, of which they found 132 that were MET amplified. And of those that were actually identified, 60 were enrolled in the study, and 45 of them were gastroesophageal adenocarcinomas. That was called cohort 1 for gastroesophageal adenocarcinoma. And so of these patients, you can see when they were treated with this therapy, and it was monotherapy only with AMG 337. It wasn't combined with anything. And so none of the patients were first line, but then you see the breakdown by the later lines of therapy. So remember, response rates tend to drop as you move from each line of therapy because the therapies usually are more effective earlier as a consequence of the cancer becoming multi-drug resistant and more hardy and resistant over time. And so in the 45 patients enrolled in this cohort across second line and higher, the response rate was 18%. Duration of responders, of those who responded, more than half of them were for more than 6 months. And the disease control rate was about half of patients at least had stability of their cancer for a period of time. And the median overall survival was around 8 months. So for this type of cancer, this is pretty impressive. The other thing to note is that MET amplification has been shown in a number of different studies is a relatively poor prognostic factor, meaning it tends to grow faster and be more aggressive compared to MET non-amplified gastroesophageal adenocarcinoma. So that makes these numbers all that even more impressive. And so that said, unfortunately, the study was closed probably just because it was felt that it was not feasible to do larger scale studies. It would be too expensive and time consuming to do that. But the reason why I always bring this up is because I still think it's important for those patients that have MET gene amplification. And then finally, there's the story of FGFR2 amplification, which is very, very similar. It's about 5% of gastroesophageal adenocarcinoma. And as opposed to EGFR, which is on chromosome 7, and MET, which is on chromosome 7, and HER2, which is on chromosome 17, FGFR2 is on chromosome 10. But otherwise, all of those 4 genes can be amplified in gastroesophageal adenocarcinoma. And so for FGFR2, if we have a tumor cell and it has FGFR2 amplification, then you have a ton of protein expression at the receptor. And so, of course, we have different ways to inhibit that receptor. And bemarituzumab is the first-in-class monoclonal antibody designed to bind to FGFR2. And in fact, it binds to just a subtype of FGFR2 called FGFR2b. So it's very specific for that. And for that reason, it's a little bit less toxic than tyrosine kinase inhibitors, which remember are oral and come inside the cell and then bind on the inside of the receptor, of which there are many commercially available FGFR TKIs for other cancer types. And so they're sort of readily available But that said, they're a little bit more side effect profile because they're not as specific. And so bemarituzumab being a monoclonal antibody just for FGFR2b makes it very appealing. In addition to that, it has the ADCC capacity by bringing in natural killer cells compared to, say, TKIs. And so combining with chemo will be easier, et cetera, et cetera. So the rationale of using bemarituzumab in FGFR2 amplified tumors, again, along the same storyline of HER2 and also EGFR and MET amplification. So this study called the FIGHT study was a study of looking at bemarituzumab, this monoclonal antibody to FGFR2, after previously showing benefit in phase 1 studies, specifically in patients that had FGFR2 amplified gastric and esophageal cancer, about 5% of the patients. This study was then designed, and it was a study that looked at first-line therapy, but eligibility included not only FGFR2 gene amplification by circulating tumor DNA, but also and/or by overexpression of the protein by immunohistochemistry. And so you could have both present, or you could be eligible even if only one or the other was present, and you had to be HER2 negative. And so you can see that this was a phase 2 study randomizing just over 75 patients in each arm, with the primary endpoint being progression-free survival, secondary endpoints being overall survival and overall response rate. I will note that this originally was a phase 3 study with a planned larger enrollment, but it was amended during the conduct of the study for a number of reasons, one of which was to really better identify what the biomarker cutoff of what was and what wasn't FGFR2 overexpressing by immunohistochemistry. And so it was downsized to a phase 2 study, and it was recently reported in the last couple of years. So in the principles of biomarker testing and tissue testing, we talked about immunohistochemistry. And in this setting, for this assay, this is an antibody, a diagnostic antibody specific for FGFR2b. And one can stain it, remember, on a scale from 0 to 3+, depending on how strong the staining is. And it's important to note that the cutoff of extensity, meaning, in other words, what percentage of the cells were positive, the cutoff for the eligibility for the study was any extensity. So like even less than 1%, as long as there was some staining at 2+ or higher, moderate staining. Now you could be eligible with this and/or if ctDNA was positive. So in the principles of biomarker molecular profiling of blood with circulating tumor DNA video, I encourage you to go back and look at. But this study was doing in parallel at the time of screening, testing the tissue biopsy, but also getting a blood sample and searching for FGFR2 gene amplification in the peripheral blood. And so either one of these being positive would make you eligible. Of course, if you had both positive, then you'd be eligible. And so 910 patients were screened for this biomarker, and 30% had positivity of at least one of these approaches. And so that's shown here in more detail. But as you can imagine, the majority of the patients that were considered positive were positive by protein expression because it was such a low cutoff, compared to those that have positive gene amplification in the blood, which was only 4% of the patients. And so some patients don't actually enroll after all of that for various other reasons, if they're not eligible otherwise, for the long list of eligibility criteria. And so ultimately, of the 910 patients enrolled, 155 patients were randomized to either FOLFOX with placebo or FOLFOX with bemarituzumab. And you can see other specifics of the study there. And so this is an important and interesting figure, and I'll take you through it. And so it's a good way to really learn about biomarkers and comparing circulating tumor DNA and immunohistochemistry. And so what we see here is each of these bars represents an individual patient enrolled in one study. And on the y-axis, you see the percentage of cells staining from 0 to 100%. And it's color-coded in shades of blue by the intensity of the expression. And so we have the intensity of expression by color code, and we have extensity based on how tall the bar graph is. And so, for example, all of these patients have really high expression, 3+ expression in a lot of their cells, like more than 75% of their tumor. On the other hand, on the other extreme, we have a lot of patients here that have just barely 2+ expression in just over 1% of the cells, but they were still eligible based on that cutoff. And so you see there that the 5% cutoff, you would exclude these patients because they didn't have 2+ staining in more than 5% of the cells, was around 76% of all of the patients enrolled. And the 10% cutoff was about 62% of the patients enrolled. So you have to be above this threshold. And the reason why I'm pointing this out is because this is now the eligibility criteria for the follow-up phase 3 studies that I'm going to talk about later. And most importantly is that, yes, this was 62% of the patients enrolled in the study, but of all the patients screened, the 910 patients, this would make up just less than 20% of the patients. Let's call it 20% of the patients would be eligible to be called high FGFR2 expressing above this criteria of 10% of the cells or more, staining at least 2+. So the next thing to show on this graph is that the pink bars are the patients who had ctDNA positivity, because remember, all patients' tumors were tested with immunohistochemistry, and all patients had a blood draw to check for circulating tumor DNA for FGFR2 amplification. And so the pink bars are those patients that had FGFR2 gene amplification in the blood. I'll also point out that this study did not check for FGFR2 amplification in the actual tissue biopsy with FISH or with next generation sequencing. So all we have is the blood for gene copy number, and all we have is the expression in the tissue. And so you can see here, there's a bunch of patients here that have gene amplification in the blood, but didn't make the cutoff by immunohistochemistry. So how can you have gene amplification, but you don't have overexpression of the protein? Usually you do, but one big possibility is that the circulating tumor DNA is picking up gene amplification from somewhere in the patient that there's gene amplified cells. Whereas the biopsy that they have, which happens to be one part of all of their cancer, doesn't have it. And in the video on principles of biomarker molecular profiling, part 3, the talk about heterogeneity, this is what we would see. And it's not surprising to me that there were some patients that did have ctDNA positivity for gene amplification, but the biopsy that was taken of the patient's cancer was negative by immunohistochemistry. So the incidences of each of these is summarized here. So of all patients enrolled into this study, the majority of them were expressing by immunohistochemistry, but were ctDNA negative. So that's like all of these bars that aren't pink. And a subset of patients were ctDNA positive, just about almost 17%, of which the majority were also overexpressing by protein, by immunohistochemistry, and some were IHC negative, circulating tumor DNA positive. That's these over here. So that's the breakdown of the biomarker distribution. It can be a source of a lot of confusion even for physicians, but it's important to understand what the eligibility was for, and because it becomes important in terms of where we think this drug will be most effective. And so this is a table just showing a whole bunch of different characteristics of the patients enrolled and comparing the two arms. And in the Principles of Clinical Trials video, we talked about the importance of randomization. And you can see here, when you randomize patients, you know, by chance, you're gonna even out all of the different parameters, whether you know about them or whether you don't. Whether it's a known parameter or whether it's an unknown thing that you don't even know that you're controlling for, but you're controlling for it with randomization. So the important one here that I'm pointing out is the FGFR2 biomarker status. And again, showing that of the patients enrolled, the majority of the patients were expressing by immunohistochemistry protein, but it wasn't having gene amplification on the FGFR2. Amplification was a smaller percentage, but of course, there was a proportion of patients that had both overexpression and gene amplification. So This is the important outcome, which was the primary endpoint, which was survival. And what you can see is in the intention to treat, all the patients enrolled and treated on study, the 155 patients. And you can see that the bemarituzumab arm, or BEMA, as they call it, did better than the placebo arm with a really nice hazard ratio. But if you start to make cutoffs a little bit higher, okay, not all the staining, but you had to at least have 5% of all the tumor cells staining at 2 plus at least. And if you did that, you see a little bit better separation of the curves compared to this figure. And you see that the hazard ratio is even lower, meaning it's getting even more discriminant. It's even better in this population of patients. And then finally, if you make the cutoff even higher and you look at only those patients that had 10% of cells at least staining 2 plus or higher, you can see that, of course, the numbers of patients having this are lower. But that said, that the curves start to improve even more and the hazard ratio goes even lower. So what this is showing is that we were able to sort of pinpoint where the real cutoffs should be for optimally selecting patients for this therapy. Now, what's not shown here, which is common, unfortunately, that is done in these reports, is that we don't see just the patients less than 5 or just the patients less than 10. But implicitly, you can imagine that there's really no benefit in those patients, because if, as you remove them from the curves, this is dropping, you must see that the other patients aren't doing well. And that's why when you add them back in, it makes the curves look worse, if that makes sense. And this is the same phenomenon that we were talking about with PDL1 expression levels in the immunotherapy discussion and video, where once you remove low-level PDL1 expressors, you start to see these dramatic improvements in outcome. And if you actually look at just the low-level patients in the few examples that are shown, there's no difference when you add the anti-PD-1 therapy. And that's the same concept here. So from this phase 2 study, we saw benefit, and we were able to pinpoint which patients are the most likely patients to benefit. Along those lines, in this forest plot, you can see that amongst the patients who had at least 10% of the tumor cells staining at least 2 plus or higher, that the hazard ratio is best compared to those that have 5% or higher of the cell staining 2 plus or higher, and certainly better than the whole population. And remember, this 10% cutoff is about 62% of all of the patients enrolled in the study, but it's just under 20% of all the patients screened. So it's important to understand who might be eligible. It's going to be about 1 in 5 patients screened by this expression analysis to see who's eligible. It's interesting that this is also the same cutoff and scoring criteria of what we use for HER2, 10% of cells, at least 2 plus or higher. The difference, though, with HER2 is that if you're 2 plus, you have to then reflex to FISH analysis to be positive by FISH to be eligible. Here, that's not the case. And so, again, looking at some key subgroup analyses, on the left is the progression-free survival forest plot, and on the right is the overall survival forest plot. You can see the overall outcomes and their hazard ratios. But when you start to look at key subgroups, specifically the IHC positive and ctDNA positive subgroup, the hazard ratios are just so outstanding. Now, again, these are relatively small numbers, and the confidence intervals are very wide because there's very few numbers. We talked about this in the statistics and the principles of clinical trials. But that said, it's very in tune with what we would expect, is that this drug, which is an FGFR2 targeted therapy, will probably work best in those patients who have the high level of gene amplification and overexpression. And so one thing to really note is that those patients that had positivity of IHC, and again, this is from the original screening criteria, meaning any staining at 2 plus or higher, and ctDNA negative, so not finding ctDNA positivity in the blood, which was the majority of patients, their benefit is still observed, but it's a little bit attenuated compared to when you included the ctDNA positive tumors. And you can see why. The ctDNA positive tumors are the ones who are really having these outstanding benefits. So what about the side effect profile of this antibody? And so remember in clinical trials, we're able to really document all of the different side effects and compare them in the two arms, the bemarituzumab arm and the placebo arm. And we can grade them on a scale from 0 and higher up to 5. And really severe ones would be considered grade 3 or higher. And so, overall, there's not that dramatic difference between the two arms. But what is highlighted is stomatitis. What that is sores in the mouth, which is higher of any grade. And there is a higher grade 3. Just under 10% of patients will have a grade 3 stomatitis. And really importantly, is ocular toxicities, where you can see there's a substantial increase in ocular toxicity in the BEMA arm compared to the placebo arm. Now, grade 3 is not dramatically higher, but there is a component of grade 3 that's here. A little bit more about these corneal events. Why do we see that? Why do we see ocular toxicity in the cornea with this drug? FGFR receptor is very active in the eye, both in the cornea, but also in the back of the eye, the retina. And I pointed out earlier that the monoclonal antibody, this BEMA drug, is a little bit better in terms of side effect profile compared to the tyrosine kinase inhibitors that are out there, which there are many. The tyrosine kinase inhibitors can affect both the cornea and the retina. They can cause retinal issues. Whereas this drug has not been noted to have any retinal issues, but really it's the cornea that's an issue. And so you get this corneal abrasion, and you can see the incidence by grade. And so what this means is that it feel like dry eye, like there's something in your eye. It's sort of painful, and to the severe degree can actually be causing blurry vision or pain. And so you can see the time to onset, the median is around 24 weeks, and the time to resolution is also a delay in terms of resolving is about 19 weeks. So patients would tend to be on it for a longer period of time, and once you stopped it, it did resolve, but it took some time to resolve. So this is a really important side effect that obviously is not desirable, and really makes you want to make sure you're giving the drug to the best patient population, those who are going to derive the most benefit, i.e., those that have gene amplification, certainly, and I'll say at this point, maybe those with high expression levels. So that's the storyline of EGFR, MET, and FGFR2. And I talked about the PanGEA study in the Principles of Biomarker Molecular Profiling, Part 3, when we talked about molecular heterogeneity and trying to study incidence of biomarkers when they're so relatively rare, not to mention the problem of where some sites have the gene amplification in the patient's cancer and other sites in the same patient don't, and how we would strategize on that. So I encourage you to go back and look at the details of this study. But just to point out, in that study again, there was a biomarker profiling and prioritization scheme that we would give targeted therapies to patients with these gene amplified tumors, EGFR, FGFR2, and MET, when we had it available. We had an EGFR therapy antibody. We used bemarituzumab when we could for FGFR2 amplified tumors, and there wasn't a MET inhibitor available for us at the time to use. So those patients were just treated with standard therapy. But it was intended that in the design that they would get a targeted therapy if and when one became available. And I showed you that patients that were treated with this personalized strategy based on their biomarker did well compared to just getting chemotherapy, and that the response rates of which is color-coded by biomarkers, you can see that, especially EGFR, contributed to that excellent response rate. We only had one patient with FGFR2 amplification who got bemarituzumab in first line, and they had stable disease. Remember, anything that is not growth above 20% is considered stable. Anything with a 30% shrinkage or more is considered a response. So anything between minus 30 and plus 20 is considered stable disease. So the disease control rate here was essentially 100%. And so remember the algorithm on all the different groups from 1 to 8. The top 5 were genomically activated. They had gene problems. and or immunotherapy with a high PDL1 score above 10. And it was a pre-specified analysis to look at the patients in those top groups that were gene amplified or high PDL1 compared to those at the relegation arms of the study, those that didn't have something better to go after. In other words, they would be what we're talking about here, the triple negatives, the HER2 negative, the PDL1 negative, eventually Claudin negative. And so we anticipated that those patients that were treated with a targeted therapy to a genetic event or immunotherapy would do better. And you can clearly see that the patients that were in the top groups did better than the relegation. So bringing it all together, when we go back not that long ago, 15 years ago, where gastroesophageal cancer was considered one entity and treated very similarly with just chemotherapy. And now this list is emerging of key biomarkers to test for. And so I've color-coded them with already standard biomarkers to check for and to treat with a targeted therapy or targeted therapy. One that's expected imminently with zolbetuximab for high Claudin expressors. I talked about the bemarituzumab story, which is based on phase 2 study, now with 2 ongoing phase 3 studies. And so it's probably the next in line, if those studies are positive, to add yet another biomarker to consider in the first line setting. And then I've mentioned EGFR and MET, but they're not being further developed at this time as phase 3 studies to change the standard of care, certainly in first line. And so it's still important to know, because if your tumor has that and it's negative for all these other things, it's something to be aware of, to look for studies for sure, or if you're a physician and you are comfortable, to consider some targeted approach towards those 2 genes. So going forward, especially when a lot of tumors can have co-expression of each of these, the incidence of each of those subgroups is not really that well established. Also, what is the best thing to do for each patient in this era right now, where most of the biomarkers will just be at one targeted therapy, not combined, other than with HER2 and PDL1. And so what is the best option? I think in the future, combining therapies is the way to go, but trying to study that and all the different possible combinations that one can consider is really challenging to study. So there are comprehensive analyses starting to emerge now, looking at like what's the incidence of patients that have Claudin positivity that will have one of these other biomarkers positive, et cetera. And so you can see on this type of figure where each bar or column is a patient, and then along the y-axis are different biological characteristics, genetic aberrations in these genes, MET expressing, overexpressing EGFR, PDL1 by different cutoffs, different color coding cutoffs, or Claudin expression. And so you can see here that they're trying to tease out what's the incidences and codependencies of each of these biomarker groups. And so as an example, something very relevant here will be what's the incidence of all negative, which is what I've been referring to in this discussion. And my anticipation is that there will still be a large proportion of patients that are triple negative for the biomarkers that will be approved as of this year. So in this video, I've talked about the specific subgroup in the first line setting that is triple negative for the key biomarkers that are already approved or really going to be approved soon, like HER2 positive, PD-L1 positive, and Claudin positive tumors, and that all-encompassing all-negative group. I also wanted to point out emerging biomarkers that do have phase 3 studies, or at least one should be aware of if your tumor has these, to consider, if not in first line, maybe in later lines, and we'll talk about that in later videos. About the first line studies looking at bemarituzumab following up the FIGHT phase 2 study, there are 2 studies. One is called Fortitude 101 and one is called Fortitude 102. Remember, to be eligible now, one has to have overexpression of FGFR2b by immunohistochemistry, at least 2 plus in at least 10% of cells. And remember, I'm sort of estimating this to be about 20 to 25% of all patients. And this has nothing to do then with gene amplification. It's not even being tested as an eligibility criteria with ctDNA as it was with the FIGHT. Now, they may be doing that in parallel just to look at what's the incidence of FGFR2 gene amplification, either in the tissue and or the blood, but it's not the primary analysis and evaluation in these studies. And then the Fortitude 101 study is being looked at FOLFOX with or without bemarituzumab or placebo, randomized in a one-to-one fashion. So this will be very important to look out for, especially in my opinion, if you know your tumor has FGFR2 gene amplification in the tissue and or the blood. This study, which there are a number of sites in the United States accruing, you should really consider. And in the second study, Fortitude 102, is a study looking at FOLFOX plus nivolumab with or without bemarituzumab and placebo. And so this study was trying to incorporate the findings from Checkmate 649, remember from the recent video we've done on PDL1, where Checkmate 649 established nivolumab with FOLFOX in all comers. The FDA approved it in all comers, and the NCCN guidelines, have differentiated above 5 or 10 and less than 5 or 10. And so for me, this Fortitude 102 study is really useful for patients who have not only gene amplification of FGFR2, but also patients who have really high PDL1 positivity. And so along the lines also of what we talked about with the HER2 story, where we showed the Mahogany Cohort A results looking at margetuximab, the anti-HER2 therapy antibody, plus retifanlimab, the immunotherapy checkpoint anti-PD-1 therapy, without chemo. But it was within super selected patients that had high copy number, high expression level of HER2, and also PD-L1 positivity by at least a score of 100. And so the same concepts and rationale can be applied to each of the genes that I just mentioned here in this talk, FGFR2, EGFR, MET, but certainly because bemarituzumab is being developed actively, this will be something to pay attention to for select subgroup of patients. So in this video, we talked about first-line therapy for a large component of the disease that will have negative HER2, negative PDL1, and negative CLDN18.2 gastroesophageal adenocarcinoma, and what to do with them. We talked about the standard would be at the moment doublet chemotherapy, preferred FOLFOX. One could consider triplet chemotherapy in select cases, as we've discussed. But I also pointed out emerging biomarker, specifically FGFR2, and differentiated expression by immunohistochemistry, which is about 20 to 25% of patients that will be screened that will have that, and the gene amplification, which is a lot less frequent, about 5% of the disease. And then I also talked about MET and EGFR gene amplification because their storyline and rationale of targeting them is very similar, and their incidence is very similar to FGFR2 gene amplification, and not that dissimilar from the 10 to 15% of HER2 gene amplification. So stay tuned for the next video, which will be bringing it all together with first-line therapy and talking about how we monitor success, how we treat with maintenance therapies and strategies thereof, and how we assess for disease progression and being prepared to transition to next line therapy, second line.